Hello and welcome to the group room where we're at the 34th annual CTRC AACR San Antonio Breast Cancer Symposium. So now I'm joined by Dr. Leslie Botnick. Dr. Botnick is a board-certified radiation oncologist practicing at the Center for Radiation Therapy in Beverly Hills, California. You're also the co-founder and medical chief officer of Vantage, Oncology. And Dr. Botnick, I've had the pleasure of working with you for so many years. You are really one of the, I can say, pioneers in radiation oncology, because you go back at a time where you trained in Boston and at Memorial Sloan Kettering, working with truly one of the true pioneer of radiation oncology, Dr. Sam Hellman.
Well, my experience goes back to 1973. Actually, Sam left Memorial without me. I came out to California, he went to Memorial. But it was an exciting time, because at the time that we started, most women got mastectomies. The first report came out in 1968 in this country, and it came out, started in 1968, but came out, I think, in the early 70s. And in Boston was the first city that really adopted the use of excision of the cancer, staging of the axilla, and radiation without mastectomy.
So you are really amongst the original generation of doctors that it was a paradigm shift for breast cancer, and you were amongst those groups of doctors that made a difference in the lives of so many women like myself who had lumpectomy radiation rather than mastectomy. In a nutshell, maybe you can tell us what's really changed in the way we treat breast cancer with radiation.
There's a huge difference. First, obviously in diagnosis, which you've covered, but in radiation, we now have the ability to shape the beam much better than we used to. We have much better ways to ensure accuracy of the positioning of a woman during her treatment. So a lot of our treatments are all now CT-based treatments. So we get three-dimensional views. If we need to see the lymphatics, we give intravenous contrast during the CT. We can shape the beam so you don't treat the heart anymore. You treat very little lung. You don't get any of those kinds of things that people worry about. You don't treat the esophagus. There's no difficulty in swallowing. And since the dose is so uniform, we can now treat things in 16 fractions to the whole breast. So the actual length of the treatment a lot of times is compressed, and only in large-breasted women or in women where we have to treat all the lymphatics do we now go to the more conventional 6 to 7 weeks. So a lot of things have changed, and especially in the delivery of the radiation.
I'm curious, how much damage does the skin have to take today in radiation therapy? Must you still radiate pretty up close to the surface?
No. In the circumstance where we're not treating somebody with a mastectomy, we actually try to spare the skin. And the skin is spared better today. We see less skin reaction. Long term, the breasts are looking great. I mean, if the surgical scar after radiation, you can't see most of the time because radiation inhibits scar formation. And what it does better than probably anything else is treat the lymphatics, because it can get beneath the pectoral muscle, could treat the internal mammary lymph nodes when needed, and treat those lymphatics without going through a lot of soft tissue. And especially what we hear now with sentinel node and the less surgery, the risk of lymphedema is probably going to be much, much less now.
Explain why when a woman has had lumpectomy, she still needs to have radiation.
Well, the breast has multiple ducts in it. We have a paired organ here. And not only is there multiple ducts in the breast where the cancer is, there are ducts in the other breast. And whatever causes that cancer affects one breast more than the other, but affects all the ducts, and especially the ducts in that breast we're going to treat, even more than the other side. So we know that when we used to do a lot of mastectomies, which sometimes I'm concerned with doing today, when people serial section the breast, they found about a 30% and sometimes a little higher risk of multifocality, some other thing, whether a DCIS, whether a small invasive cancer somewhere else in the breast. So the radiation is able to kill small collections of DCIS, tumor cells, and so we see cure rates exactly the same as mastectomy, and in some circumstances I believe it's actually a little bit better.
And we just want to drive home so women understand when you don't have a mastectomy, you're going to have lumpectomy, that the treatment of lumpectomy, surgically removing the tumor, isn't complete until you have finished it off with radiation.
Correct, and especially in invasive breast cancer. And the only time we use lumpectomy alone is in very low-grade DCIS of very small breast cancers in somewhat older women. We're not concerned about long-term results.
You mentioned something a few minutes ago that we're going to come back to because I know it remains a real concern, and that is what you consider the overuse of mastectomy. And I want to talk about that because there are women who I know you have seen that you have felt could have gotten away with treatment using radiation rather than a more aggressive surgery to remove a breast or both breasts.
With the techniques today, especially, probably 90% of women don't need to have a mastectomy. And if you don't have a mastectomy, there sure is no reason to have a bilateral mastectomy. When you remove the removal of both breasts once you've had an invasive breast cancer, improves not one iota the survival. There are no differences. There is no scientific published data that shows taking both breasts off at the time of development of a breast cancer improves curability. Women get frightened. It depends who you talk to. If somebody says to you, well, there is a risk you can get something on the other side, you say, oh, the way to help me stay alive for the rest of my life is, well, I'll take all the breast tissue off. Well, first, you never take all the breast tissue off because mastectomy, even the old modified radical mastectomy, doesn't take all breast tissue. Skin sparing takes less. If your nipple sparing takes less. So in essence, anytime we've compared these studies with invasive breast cancer, bilateral mastectomy does not improve curability. So why do it if you don't need to do it?
So what many women will say, I feel safer. I would prefer to have the breasts gone because psychologically, if my breasts are gone, I don't feel as vulnerable.
I think a lot of it is in the presentation and the way people talk and explain to people. Most of the time, I don't see a woman when she presents. So she's already seen one or two surgeons, a plastic surgeon who a lot of times really knows nothing about radiation or has a very negative feeling about radiation. They may see a medical oncologist before, but those decisions is based on a cursory review and sometimes a presentation. And a lot of people want more security. I mean, but we do things. We travel on buses, even though there's a risk to being on a bus or a plane. And here we have no credible scientific basis of risk. It's a fear. Sometimes you can't change fear, but if you don't get all the opinions, and if it's not presented in a fair manner, you're probably going to make an appropriate decision.
I think one of the areas of big change too was when I was diagnosed, your medical oncologist or your surgeon referred you to the radiation oncologist at the hospital, and you go down to the basement and you get your radiation therapy. Today, patients have the option of going into the community and seeking out and interviewing radiation oncologists.
Well, there's a lot of freestanding facilities that are close by the homes. And since the treatment is a daily treatment that can occur over 4 to 7 weeks, you really want to have something that's accessible. You can get as good as treatment in a lot of these centers as you can get in academic centers, and sometimes better. So you do have that ability, and you have the ability to interview, find out what kind of equipment, what kind of doctor, what kind of experience, and what kind of physics is done at the center. Do they have a physicist there all the time? Things like that.
And can you please explain why the physicist is so important?
Well, it's check the equipment, making sure that we're planning and there's a review process. You don't want one person looking at anything, and you always have to have checks and balances. So you want a physicist, a dosimetrist to review those plans. I mean, those plans are very complex. There's multiple fields sometimes we do, and you want to get the best results. You want to know they're board certified, just like I'm board certified. There should be a board certified physicist, there should be a board certified dosimetrist, and even an oncology nurse. So I think there's a lot of people you sometimes, I don't know if you have good bedside manner in the one doctor, you say, oh, that's terrific. And that's not always the best thing. You got to see what the equipment is and what is his staff.
What about radiation therapy used in the operating room?
This is the partial breast. It's sort of electrons in the OR. They can actually do this. And it's like a boost. I don't think there's any, as long as it's a conjunction with whole breast radiation, I think it's just fine. But a lot of times in the OR, you don't know the margin, so you don't know the dose you should be giving. You can get a frozen section. So sometimes technology is used for technology's sake. And I think we, again, if you want to study this and you want to look at it, of intraoperative electron beam or whatever, which I said I don't want to give a name of a product, that's just fine. It's okay to do that. But do it under a study. See if it's any better than external beam boost or if it's needed, and just compare those results.
And you were saying that the 6 to 8 week course of what has been standard radiation therapy today may not be necessary to treat that long?
In anybody who does not need lymph node radiation, I suspect that 70% of women can be treated in approximately 4 weeks.
If one has had any positive nodes, will they require lymph node?
Sometimes, again, it's to the extent. If you see a few cells in the lymph node and they did have, it's an outer quadrant lesion, meaning, it's very close to that lymph node. Radiation itself, just treating the breast, will treat that level 1 lymph node region. So the answer is you don't always need to have more extensive radiation than the 4 weeks of radiation that we're talking about.
Dr. Botnick, you mentioned IMRT before, and we should expand on that a little bit, and also some of the different types of, I guess, are they modalities of delivery?
It's the machines have changed. And they're now, mostly any new machine has the capacity to move the head of the machine's blocking system while treating a field. So in reality, you can actually rotate the machine, and what the machine is looking at from different angles. Some angles it sees the breast and no lung, so they're going to treat more. In other angles, you can see mostly lung and a little breast. So those leaves will close, and they do it very fast.
You're talking about the leaves on the machine, where the beam comes.
Doesn't touch you. So whether it's a form of radiation called, it's called rapid arc, it's called VMAT, it's all kinds. So the machine is rotating, and these beams are changing. Now, when you treat the lymph nodes, because the field is so a little bit wider, meaning the lymph nodes are beneath the sternum, you got to treat the lymph nodes underneath the muscle, you may indeed have to use that form of treatment where you modulate the radiation beam and you vary the intensity of the beam as it's moving, so hence IMRT. Even with the fixed field breast, where it's just treating the breast alone, you may want to modulate, but we don't call that IMRT. It's kind of simpler, but it is a form of forward planning IMRT. So the techniques have totally changed. The side effects are markedly different by using better contouring, CT scan-based planning, and IMRT when necessary, but not always necessary in every breast case.
Dr. Botnick, what is image-guided radiation therapy?
Today, all machines come equipped with the ability to take regular x-rays or do modified CT scans on the machine. So you actually can do the setup, what you plan at the time of the CT simulation, and make sure it matches, make sure the exact field arrangement is correct. So you can do that every day, right prior to the treatment. You could even stop it if it's a complex treatment and do it during the treatment. And if in certain circumstances you actually can put a seed into, a type of seed into the breast, which is really not being done a lot, and actually follow that during the course of the treatment. So image guidance is exactly what it says. It's almost like a GPS of radiotherapy, where you can ensure much better that the breast isn't moving, and we now can even measure the dose during the radiation. So if the cavity, which changes during radiation, changes a lot in the dose where the region of the excision is changing, you can modify the physics planning of your treatment.
So in closing, if you had to project what your hope is for the future of radiation oncology, what would it be?
We continue to refine the way we deliver the radiation, and I stop feeling that I'm in a Groundhog Day, where I'm back in the 60s and 70s, where all these women are now getting mastectomies and bilateral mastectomies and not even asking the question. I think those laws were changed to give women the right to ask the question, and now that we have the science to back the fact that you don't need to have this procedure done, why get it done?
Thank you, Dr. Botnick. Dr. Leslie Botnick, co-founder and chief medical officer of Vantage Oncology.
Thank you, Selma.